Hi, Dr. Akki.
Hello, can you hear me?
Yes, I can.
Okay, cool. Give me 1 second. Oh, I have to let you know, colleague of mine is had to leave, so I've offered a volunteer to cover Frozen's between now and 5. So in case they call me, I'm hoping they won't, but in case
Well,
they,
that's pathologist life, so that's fine.
yeah. So let me share my screen. Give me 1 second. Can you see the screen?
Yes.
Okay, cool. Okay, so today I thought I'll go through some of the lesions in the pancreas that I have. Some of them are cystic lesions, the others are more like solid lesions. So we'll see what we can get through. And then, did you guys have a session on pancreas itself, like the Kurt's notes and stuff?
No, not yet. We haven't
Okay,
done that yet. Yes.
okay. Well, in that case, this is probably the, the first session then. So these were some of the unknowns that I've been I recently gave to our residents. So let's start with the first one here. It's a 45-year-old female with a 3-centimeter solid and cystic lesion in the body of the pancreas. And this is what I have. I'll slowly move around. So just to give you guys an example, here is the background pancreas. This is the pancreatic duct. Let's see, is it blurry? Okay. So, and then here is the lesion. As you can see, it's somewhat circumscribed. The periphery is the pancreatic tissue, and then this lesion, very cystic. And then when I go closely, the cysts are lined by these somewhat monotonous looking cells. As you can see, pretty bland and monotonous. So does anyone want to know additional history? I can tell that I can say that the cyst does not communicate with the pancreatic duct. Anyone wants to speculate what cyst this might be and suggest any staining if needed? You could make an H&E diagnosis. You don't necessarily need a stain. Or do we have too many participants here?
We have some.
Okay, we have Charles Middleton here. Oops, I don't know if he's away or not.
Yeah.
Anyone wants to?
We have Snehal here. Snehal is here.
Sure.
Well,
Well,
it's been a while. I am not looking at pancreas. I do not see any ovarian type of stroma in here.
Correct. Yeah.
That was one of the things I was looking for.
Yeah.
And mucinous cyst, that is one of my other differential, but looking at the epithelium, it doesn't look like quite mucinous there.
No. So, yeah, what are the other cysts that you can encounter in the pancreas?
Solid pseudopapillary, but this doesn't look like that as well.
Right.
Um,
So the epithelium is very bland, right?
yeah.
And it's not mucinous, like you rightly noted. So it's not a mucinous cyst. So, you know, the two major things that we can think of in pancreas are mucinous cysts and non-mucinous cysts. In the mucinous cysts, we have mucinous cystic neoplasm and IPMN, right? Intraductal papillary mucinous neoplasm. So once we exclude mucinous, we have the non-mucinous cysts. And what's one of the more common non-mucinous cysts?
Is it a retention cyst of some kind?
No, retention cyst is just dilatation of pancreatic duct. This is a true cyst because it has a, I don't know why it is green on the screen. This is a true cyst.
Is it a serous cyst adenoma, the one with spongy looking and multiple cysts? And
It is.
grossly, it has a scar in the center.
Correct. Yes, that's what it is. It's a serous cyst adenoma. So see how innumerable the cysts are? These are microcysts. So microcysts are anything less than, 0.1 centimeter-ish. So these are really small cysts. They look big on a microscopy because now I'm at like 4 or 10x, but otherwise these are really small cysts. So this is microcystic, and it's lined by this very bland looking cuboidal epithelium, which with basally located nucleus. And if you pay close attention, see the innumerable blood vessels in the septa that's lining these cysts. So that's somewhat reminiscent of another tumor in the body, which we will go to in a minute. But overall, one, from the history, it's a female patient, and two, it's well circumscribed, like on low power, like I said, and then it has these innumerable cysts. It doesn't have ovarian type stroma, and so it's not lined by mucinous epithelium, so it's a non-mucinous cyst. And so serous cyst adenoma is the answer, but there are subtypes, right? There's macrocystic, microcystic, and solid. So this is microcystic. If the cysts are larger than 1 centimeter, then it's macrocystic. Anything between 0.1 to 1 centimeter is microcystic. And then if it's solid, truly, then it's a solid serous cyst adenoma, which are very rare. So this is microcystic serous cyst adenoma, and grossly, boards can test you and say, give an image of the cyst, which has a spongy appearance, well circumscribed cyst that has a central stellate scar, and that's your clue for serous cyst adenoma. Now, does anyone remember what mutation these cysts have? Again, molecular testing is not routinely done on these cysts, but if you were to do one,
is that a VHL?
Yeah, it is VHL. So
Okay.
There are two types of VHL changes that you can see. In syndromic patients, you see the mutation which is located on chromosome 3, the VHL gene on chromosome 3, and in sporadic cases, you see loss of heterozygosity. So if you were to do molecular testing, about 90% of these cases, even non-syndromic, will have that mutation. And so where else would you see that mutation? What other tumor in the body?
RCC.
Renal cell
Yeah,
carcinoma.
renal cell carcinoma, right? And hence the morphology. See all these small punctate blood vessels, like capillaries? That's something that you would see in RCC, right? So, so histologically, that's something that can remind you of the RCC architecture. But regardless, yeah. So this is a microcystic serous cyst adenoma. The prognosis of these cysts is very good. They're, if they're smaller than 3 centimeters, they're usually not taken out. They're just followed. They're only taken out if they're symptomatic, or if they're somewhat larger in size and if the imaging is not kind of specific. They're taken out of concern, thinking that they may be mucinous if the sampling or cyst fluid analysis is not helpful. So invariably, when there is a cyst in the pancreas, the clinicians have a multi-step approach. These days, the cysts are coming to attention more and more early, mainly because patients come in for other disease processes to get checked, or they're involved in a road traffic accident and their whole body CT or PET is done, and then these things come to attention, and then they follow it up and investigate it further. And that's why the size of the lesions these days of pancreatic cysts are much smaller compared to previously. So they are followed carefully. And so the multi-step approach that the clinicians do is first is imaging. And then once the imaging has certain features, mainly the size, if it's greater than 3 centimeters, then they go after it. Or if the imaging shows a mural nodule, then they go after it. And the second step is they try to sample it, which they do by FNA. And when they do FNA, they're getting two different things. One is the cyst fluid, which they send for chemistry, cyst fluid analysis. And then the second is, any cells in cytology that might reveal what kind of cyst this is. Cyst fluid analysis, there are two main things that they look at. CEA levels, which if elevated tells you that it's a mucinous cyst. And then amylase level, which tells you if it's elevated that the cyst is communicating with the pancreatic duct. So in serous cystadenoma, both are low because it's not a mucinous cyst and because it's not communicating with the pancreatic duct. Does that make sense? Any questions? I'm hoping I covered everything associated with this cyst.
That was a good example. Thank you.
Yeah. So this other cyst, again, you have to just take my word for it because it's actually not in the pancreas, but I'm still using it as something that, because you can see something similar in the pancreas. So 35-year-old female with a 5 centimeter cystic lesion in the head of the pancreas. And so this is what I have. The cyst is somewhat thin walled. Let me bring you to the epithelium. Give me 1 second. Okay. Here is the epithelium. So these are real life examples, and a lot of times the epithelium may not be as revealing as you think it is, or as you think it would be. So you have to use everything else that's associated. Unfortunately, that was the best focus, so I'm going to go back to that focus, and we have to, let's look closely at just the epithelium and the tissue underneath the epithelium.
Yeah, the stroma looks kind of funny. Is it endometriosis? The stroma looks over,
So if the stroma looks different, what's it?
Ovarian type, I think.
Yeah,
Yeah.
it's an ovarian type stroma.
Yeah. And the epithelium is not quite mucinous,
Correct.
but I think these can have like a gastric foveolar type of kind of epithelium and some other types of epithelium, right?
Well, it is actually, at least originally, it's a mucinous epithelium, but when these cysts become really enlarged, they're filled with secretions, right? So the epithelium can become attenuated and kind of lose its mucinous appearance.
Mm-hmm.
And so it almost looks like a serous epithelium with no mucin in there.
Yeah.
And lack of mucin should not dissuade you from making this diagnosis. If you see, that's why, I mean, one thing though, mucinous cystadenomas should be sampled entirely because there is a chance of focal high-grade dysplasia and carcinoma in these. So the cyst should be sampled completely. And when you completely sample it, there will be like one focus where there will be mucin in the epithelium. So I think this one did have very focal mucin. I'm trying to see where that focus is. But like I said, lack of mucin should not dissuade you from making this diagnosis. The fact that you're seeing ovarian type stroma, what would you do to prove that this is mucinous cystadenoma?
So we can prove that it is ovarian stroma by ER, inhibin.
Yeah. So you can do ER, PR, and inhibin, right?
Yeah, yeah.
So ER, PR, and inhibin help you stain the most helpful stain that I've found so far is PR because somehow the ovarian type stroma in mucinous cystadenomas picks up PR really well. But other stains can be done too. And so if the stroma picks up, then it's more likely to be mucinous cystic neoplasm. And then, once you know that this is mucinous cystic neoplasm, what's the next step? Do you stop at that? Remember,
You
I said
ask
you have.
them.
Sorry?
Sorry, I said you asked them to submit more.
You're right. You sample the whole thing, and so you look for any dysplasia. So, if there's low-grade dysplasia, high-grade dysplasia, you report it, and you look for cancer. So you top line it as, if there is cancer, then you say invasive adenocarcinoma arising in a background of mucinous cystic neoplasm. If there's no cancer, then you say mucinous cystic neoplasm with focal high-grade dysplasia, etc. Give the size of the lesion, and then you can move on and say that the cyst was submitted entirely. And so these cysts, again, when the clinicians get them, like I said, they go through the stepwise, right? So they do imaging, they know the size of the cyst, and they want to look for any intramural thickening of the wall, and then they do FNA and get the cytology specimen as well as the cyst fluid. And so because this is a mucinous cyst, the cyst fluid CEA levels are elevated over 200 nanograms per milliliter. And then the amylase is, of course, within the normal range because these cysts do not communicate with the pancreatic duct. And then the low-grade lesions can have some KRAS mutation, molecular wise. And then, high-grade ones acquire additional mutations like P53, PIK3CA, etc. So high-grade and invasive cancer have very similar or same mutations. So those are the highlights for mucinous cystic neoplasm. Any questions?
Is there a size cutoff of any kind?
Is there a size cutoff
Mm-hmm.
for calling it mucinous cystadenoma, mucinous cystic neoplasm?
Yes, like for a simple mucinous cyst, you have to be having like more than 1 centimeter, but then there is no ovarian type stroma. So for the mucinous cystic neoplasm, is there any cutoff?
Usually, I mean, once you see the ovarian type stroma, you don't worry too much about the size, but if you have to go by WHO, I think anything greater than 0.1, they revised it. Previously, it used to be anything greater than 1 centimeter. But I think recently they said anything greater than 0.5 centimeters. So,
okay, got you.
Now this one is a fun one. 65-year-old male with a 4 centimeter lesion in the body of the pancreas. So I'm trying to see. So there is the pancreas. Background has chronic pancreatitis going on. There's the pancreatic cyst duct. And then here is the lesion.
Does the patient have a clear cell carcinoma of the kidney?
He does. So yeah,
yeah.
this is metastatic renal cell carcinoma to the pancreas.
Yeah, renal cell carcinoma is
Yeah,
very
it's
bad.
yeah, it can be very tricky and very
Yeah,
sneaky.
yeah.
Now pay attention to the blood vessels. Doesn't this remind you of what we saw in that serous adenoma?
Right, yeah.
Yeah.
Okay. Now this is another cyst. Now this time this is a 5 centimeter cyst in the body of the pancreas. Imaging revealed unremarkable main pancreatic duct but dilated branch duct. And this is what we have on LOPAR.
Looks like tubulopapillaries of some kind.
Yeah. So
That there was an entity intraductal tubulopapillary neoplasm. I mean, it resembles that, but I don't know.
so what's the epithelium lining look like? If you were to go here and look at it closely. What epithelium in the body does this?
Looks like gastric.
Gastric, yeah.
Yeah. Gastric foveolar type. Okay. So yeah, gastric foveolar type epithelium that's forming this cystic lesion in the pancreas. And I said it's a,
IPMN?
yeah, it's an IPMN, intraductal
Yeah.
capillary mucinous neoplasm, gastric phenotype, gastric type.
Right.
See, look at the epithelium.
Yeah, it is very classic. Epithelium.
No. So IPMN, there are 3 main subtypes, epithelial subtypes: gastric, intestinal, and pancreatobiliary. Gastric is the more common. In 70% of the cases, we see gastric. In about 20% of the cases, we see intestinal. And then I'm trying to see if I have additional, no, okay. And then about 5 to 10% you'll see pancreatobiliary. Okay, this is the next case. It's a 3 centimeter lesion. In the head of the pancreas, and imaging revealed a dilated main pancreatic duct. That's the lining epithelium of the duct. I'm showing you the particularly characteristic areas. I'll go LOPAR so you can appreciate the cyst itself.
Looks like tannin to some extent as well.
Well, tannin is a size criteria, right? Anything less than 0.5 centimeter. This is 5 centimeters.
Oh yeah, that's true. This is more.
Is this pancreatobiliary type IPMN?
It is.
Oh, cool.
So this is the pancreatobiliary type IPMN. So how do we know that? Because in the gastric type that we saw earlier, let me quickly go back. We had the gastric foveolar type mucin, but also look at the nuclei, basally located, right? And then this case focally also has intestinal type. This villiform here, not pretty classic, but there is a little bit of intestinal type. And you can see some elongated nuclei, but not too many. And so that's kind of intestinal type IPMN. But in the pancreatobiliary type, how did the nuclei look? Are they basally located? They're apically located, a lot of them. So there's loss of polarity in the nuclei. They're enlarged. They have prominent nucleoli or variably prominent nucleoli. There is loss of polarity. So this is by default a high-grade lesion. So gastric and intestinal IPMNs you grade as low-grade and high-grade. The moment you see pancreatobiliary, it's considered high-grade by default. Look at these nuclei. Remember the gastric type, they were so basally located, much smaller than these. So this is pancreatobiliary IPMN. Now, you can do stains to differentiate these, but staining is not routinely done. It's more of a morphologic diagnosis. Patients with pancreatobiliary IPMN progress to invasive cancer much faster than those with gastric and intestinal type IPMNs. One of the associations is for intestinal type IPMNs can give rise to mucinous carcinoma of the pancreas, known as colloid carcinoma. That's tested frequently on the boards. So intestinal type IPMN is a precursor lesion for colloid carcinoma in the pancreas. Mutation-wise, intestinal IPMNs have KRAS and GNAS mutations, majority of them. And then when they advance, all of them will have the TP53 and PIK3CA mutations, SMAD4, etc. The ones that you would see with pancreatic cancer. This one is a 65-year-old male with 7-centimeter cystic lesion in the head of the pancreas, presenting with jaundice and weight loss.
Is that the oncocytic variant of the IPMN? What do you call it? This intraductal oncocytic papillary neoplasm, right?
It is. Wow. I don't need to teach you guys anything. You guys know it all. So yes, it is. So previously, before 2019, this used to be a subcategory in IPMN known as the oncocytic subtype. But in 2019, the WHO made this an independent entity by itself, and it's now called IOPN, intraductal oncocytic papillary neoplasm. So the characteristic feature is on low power, it has this innumerable papillae formation. And then when you look closely, the cells lining these papillae are pretty large and eosinophilic, granular eosinophilic, abundant granular eosinophilic cytoplasm. The nuclei by default are pretty high grade. If you remember, these nuclei look like the pancreatobiliary subtype nuclei, have prominent nucleoli, nuclear grooves, etc. And then there are occasional intracytoplasmic mucin or goblet cells. We have to hunt for them, but they're there. The reason they made this into an independent entity is because they found a entity-defining mutation or translocation in these. So they noted that the a number of cases have these translocation partners, DNA JB1 with ATPB1. And that's something that you see with fibrolamellar HCC. So once they found that entity-defining molecular change, they felt convinced that this was worth being an independent entity by itself. And the prognosis of this is slightly worse than that of conventional IPMNs. But otherwise, yeah, morphology is pretty revealing.
This is the first case I'm seeing of this entity.
And you made the diagnosis. So this is a 48-year-old male with dilated main pancreatic duct. Let's see what's going on here. Oh, I think we already have seen this entity. So it's a repeat, I think. This is just the gastric foveolar type IPMN. So, now this one, okay, this is just a garden variety pancreatic ductal adenocarcinoma. I think I had this slide mainly to highlight a couple of features. Now there are 7 features of pancreatic cancer that, if present on a small biopsy or cytology specimen, are considered pathognomonic. These 7 features were classically highlighted by Dr. Ralph Ruban at Johns Hopkins, but eventually a lot of people mentioned this. But one of the features is what we see here, perineural invasion, right? Perineural and intraneural. And I think there was one more here. And then the second feature is luminal necrosis, which you can see a lot, here, all the luminal necrosis. And then the third feature is a LOPAR feature, haphazard arrangement of glands. See how haphazard they are. And then, let's see. And then the fourth feature is like naked glands in adipose tissue. So we have adipose tissue here and we have these individual glands, right? And so that's another feature. And I thought there was one other classic feature here. Of course, when I'm searching for it, I won't find it. So the other feature that I'm looking for is intravascular invasion, meaning like intravascular growth. It's not just lymphovascular invasion. You actually have a thick-walled artery, and the tumor cells actually replace the endothelium in the artery and start growing. So that's something that you can see with pancreatic cancer. And then perivascular glands also. Anyway. Okay, this is another, number 9, it's a 55-year-old male with 4 centimeter pancreatic body mass. And from LOPAR, you can already see that this doesn't look right. It's abnormal, so it's tumor, right?
Yeah, sure.
The question is, how would you morphologically classify this tumor. And when you go closely and look at it, how does this morphology look?
Neuroendocrine.
Squamoid.
Yeah, someone said squamoid.
Yeah.
So this is actually Adenosphamus carcinoma of the pancreas. These do worse than the regular adenocarcinoma of the pancreas. And to make this diagnosis, you need to have at least 30% squamous component. So you have to look at a lot of tumor, or at least a decent number of sections before you call it or top line it as adenosphamos carcinoma. And if it's only focal, you call it adenocarcinoma with focal squamoid or squamous differentiation. But if it's like 30% or more, you can call it top line it as adenosphamos carcinoma of the pancreas. And this was one of the cases that we top lined it as adenosphamos carcinoma of the pancreas. Neuroendocrine is a good thought, but a lot of times when we are faced with that, do you really see these many ugly nuclei in neuroendocrine differentiation? Then it would become a neuroendocrine carcinoma, right? And if we did a P40 stain to support our diagnosis and it was strongly and diffusely positive, so we went with adenosphamos carcinoma.
Right.
And so this next one is a 40-year-old female with a 7-centimeter solid and cystic lesion in the tail of the pancreas. You can already see from LOPAR that it's a cystic lesion. I'll go closely. Go higher. You can see this, the tumor cells look somewhat monotonous, but there's also these hyaline globules between the tumor cells, lots of them. And that's a hint.
Solid pseudopapillary?
Yeah, that's what this is. So if you're in doubt, how would you confirm that this is solid
Beta-catenin?
Beta-catenin.
Nuclear.
Yeah, nuclear beta-catenin. You can also do CD10 staining. What if you did synaptophysin? Would it pick it up?
It should be ideally negative, no?
No, it can pick up synaptophysin. So sometimes it's patchy. So that's why if you're doing neuroendocrine markers, you should do both chromo and synapto. Don't do one and call it neuroendocrine. That's why doing a nuclear beta-catenin will support you. Okay. Now this one is a 72-year-old male with an 8-centimeter pancreatic head of body mass. So on LOPAR, we have a little bit of pancreatic parenchyma here. Am I going fast?
No, you're at the right pace.
that's
Very
fine.
good.
Okay. So we have background pancreatic parenchyma here, as you can see, acini ducts. And then as I move away from the pancreatic parenchyma, lots of hemorrhage, hemosiderin. What else do we have?
Giant cells.
Yeah. So quite a few giant cells. Okay. So we saw giant cells. I keep moving. I come to the middle of the lesion. So would you just disregard this as giant cells?
They're pretty
Ugly
atypical looking.
type cells, yeah.
Yeah, they look ugly, right?
Yeah.
So, so it is a tumor, but it also has these admixed giant cells. And despite submitting or sampling the tumor extensively, let me focus on this area so you can see the ugly nuclei of the tumor. Look at these nuclei. The giant cells, but then there are these ugly nuclei too. Despite extensive sampling, I couldn't find a glandular component. There's no other tumor anywhere in the body. This is the only tumor that the patient has.
Is it like osteoclastic giant cells?
Yeah.
It's almost like an anaplastic carcinoma of pancreas, but it is so rare that I don't want to utter it.
You're close, but not there. You're very close. So this is actually undifferentiated carcinoma of the pancreas with osteoclast-like giant cells.
Okay.
So the way you make this diagnosis is you have to first search to make sure that there's no glandular component, right? Because you're calling it undifferentiated. Then the second thing is you do a keratin, and all these ugly tumor cells, this one has a very abnormal mitotic figure, right? So all these ugly tumor cells will pick up keratin. You can do pan-keratin, CK7 or CAM 5.2. And then what about the giant cells? Do you think they'll pick up the keratin or not?
I guess they will.
No, they won't. So in the undifferentiated carcinoma with osteoclast-like giant cells, the giant cells are benign. So the giant cells stain with histocytic markers like CD68, but they don't pick up keratin. And there is another type of similar cancer, just like you were mentioning, the osteoclast-like, Akanksha was mentioning, the anaplastic. And that one also looks very similar, but there the giant cells are also malignant. And there, both the individual tumor cells and the giant tumor cells pick up keratin. That's how you differentiate the two.
Wow.
Does that make sense?
Yeah, this entity I haven't heard of, so yes. Undifferentiated pancreatic cancer with osteoclastic light giant cell. That's what it is called?
Yeah, undifferentiated carcinoma with osteoclast-like giant cells.
Nice.
And I'm sorry, what's the other entity that you were differentiating it from?
Anaplastic carcinoma of the pancreas.
Okay, thank you.
Okay. So this other case is a 47-year-old male with a 2.5 centimeter pancreatic head mass. So on low power, let me see. There's not much pancreatic parenchyma here. Looks like there is the ampulla on one side here, then the lesion itself. So let's go look at the lesion per se. So it looks very glandular or trabeculated. And then when you pay attention to it, it's very easy to like think of it as conventional ductal adenocarcinoma. It somewhat looks slightly different. And then when you go closer and look at the cells themselves, do you see the pink granules in the cytoplasm?
Yeah, that's zymogen, is that the one?
Carcinoma.
Yeah, they're zymogen
Yeah.
granules.
Yeah.
So this is acinar cell carcinoma of the pancreas. When we did trypsin chymotrypsin, it lighted up. And so paying close attention to morphology is very important. And the next one is a 1.7 centimeter lesion in the tail of the pancreas in a 53-year-old female. So it's pretty well circumscribed, as you can see. There's pancreas at the periphery, and then the lesion is here. It's not too infiltrative. Then when we go closer and look at the morphology, the cells are arranged in, the tumor cells are arranged in cords and nests. Pretty monotonous.
I know what you're coming at.
Anyone wants to take?
Neuroendocrine.
Yeah, so this is a well-differentiated neuroendocrine tumor grade 1, I think that's what we called it. So neuroendocrine tumors, we always do synaptochromal Ki67, and then just to be on the safe side, more recently we've been doing a CAM too, because neuroendocrine tumors should pick up CAM, but paragangliomas don't pick up CAM. So that's why we're doing it, but morphology is pretty helpful. And then, Ki, we use it for grading. As you know, neuroendocrine tumors in the GI tract are, especially in the pancreas, they graded as well-differentiated grade 1, 2, and 3. And then anything worse than that is neuroendocrine carcinoma. And then, Ki less than 2% is grade 1, 2 to 20% is grade 2, then greater than 20% is grade 3, but neuroendocrine carcinoma is also greater than 20%. So how do you distinguish well-differentiated grade 3 versus neuroendocrine carcinoma? If the morphology is well preserved still, if the tumor cells are forming, nests and trabeculae, instead of being, haphazard and invading, then it's called well-differentiated neuroendocrine grade 3. The reason they came up with that particular category was because they noted that in studies where they followed up the patients over time, even though patients with both category have Ki greater than 20%, those which had a well-differentiated morphology did better compared to those who did not, which is why they decided that well-differentiated neuroendocrine grade 3 should be a grade by itself, category by itself, rather than calling it neuroendocrine carcinoma, just because Ki is greater than 20%. So that's that. I'm trying to see what else I have. I think that's all I have. Those were the highlights.
That was a wonderful session. I loved it.
Good. Any questions?
Dr. Akki, there's another entity, pancreatoblastoma, that also has kind of squamous cells, which are
Yes.
the flu.
Mm-hmm.
So the morphology would be different than adenoid squamous PDA, right?
Yeah. So pancreatoblastoma, what kind of patients do you see it in?
It would be
Children.
young patients,
Yeah.
kids with round blue cell.
Yeah. So it's pediatric population, right?
Mhm.
So age is a big giveaway. And the second thing is, even though you see squamous, it's not just squamous differentiation. You actually see squamous morules, right?
True. Yeah.
Yeah. So those things should help you
Mhm.
make that diagnosis. And it's very rare, but if you're in doubt, you can always send it out. But my hunch is when you encounter that, just the age of the patient and the presence of squamous morules will at least make you think that
Mhm.
that it's a pancreatoblastoma and not adenospheric carcinoma.
Okay.
There is one more rare tumor. Give me 1 second. I'll show you. It's extremely rare, and WHO is yet to incorporate it in their classification. Let's see. So we have the background pancreas here. This was a 64-year-old male who presented with a 4-centimeter pancreatic lesion. Before, like I said, the workup for pancreatic lesions is pretty similar. On imaging, if they see a lesion, then they try to characterize how it looks on imaging. And then they try to do either a needle core biopsy if it's a solid lesion, or a FNA if it's a cystic lesion. And this one, they tried to do, because it was focally cystic, they tried to do an FNA. And they got some cells. This is how the tumor looks. They got some cells, and I won't say what it was called, but I just want you guys to look at the morphology and appreciate what it looks like from low power or high power. What tumor does this make you think of? In some areas, it's pretty monotonous looking. In others, there are some prominent nucleoli, but overall, it looks more low-gradish. See the trabeculae formation? Any thoughts?
Makes me.
Hmm?
It makes me think about hepatocytes. Let's see.
Oh, hepatocytes?
Yeah, prominent nucleoli, trabeculae.
Okay. But the cytoplasm is not that abundant, right? Like a hepatoid or hepatocellular carcinoma. The nuclei are more prominent than the cytoplasm here, no?
Yeah, true.
Because if it's a HCC, usually cytoplasm is more primary.
I mean, the nuclei are not good for neuroendocrine, but that's like kind of trabeculae and all monotonous could also be.
So the trabecular and the nested nature is good for neuroendocrine. But the nuclei, what do the nuclei remind you of? In the pancreas, what What tumor?
Adenocarcinoma.
Well, prominent nucleoli like this, what's the characteristic feature of?
Is this a metastatic tumor or is it a
It's a
primary?
it's a primary.
Acinar
Acinar,
cells.
acinar
Acinar
cell
cells,
carcinoma can have prominent nucleoli syndrome.
Correct. Yeah. So it has the morphology of a neuroendocrine tumor because of trabecular formation, but it has the cytology of acinar cell carcinoma because of prominent nucleoli. And then what's this?
Is that those granules?
Yeah, zymogen granules. So when we did stains, so this is synaptophysin. The whole tumor is picking up synaptophysin, just like a neuroendocrine tumor would.
Mhm.
And then we did chymotrypsin,
Oh.
and the whole tumor is picking up chymotrypsin,
Mm.
just like us in our cell. See that? So neuroendocrine tumors, well, acinar cell carcinoma, about 30% of the cells in acinar cell carcinoma can pick up neuroendocrine markers. But in this case, 100% of the cells were picking up synaptophysin, and 100% of the cells were picking up chromogranule and trypsin, sorry, chymotrypsin and trypsin, as well as chromogranule and synaptophysin. What name would you give this tumor?
Mixed acinar
Mixed.
neuroendocrine.
Yeah, you're close. So we call this amphicrine carcinoma, meaning that it has both neuroendocrine as well as exocrine and endocrine differentiation. The same tumor cell. We also did electron microscopy and saw two types of granules within each cell, each tumor cell. Neuroendocrine granules are usually less than 200 nanometers in size, and then amphicrine or the zymogen granules are greater than 500 nanometers. So we had two populations of granules in each of the tumor cells. So it was an extensive workup. So that we had evidence immunohistochemically, morphologically, electron microscopy wise. And so we call this amphicrine carcinoma, which is a name given to very rare tumors which have 100% expression of both components, exocrine and endocrine. Mixed is given even if there is partial expression of different components, but amphicrine is reserved for tumors which have 100% expression of both markers. So we came across another case where we had greater than 80% expression as well. So we published it earlier this year. So let's see, it should be here.
It would have been cool if you had the EM picture as well.
It's in the paper, I think. Let me.
Oh wow, is it? Yeah, I will be interested in that. I have done the renal pathology and I have done quite many EMs. So
Yeah.
EM excites me.
So give me 1 second. I'll see if the paper comes up. It's loading. Any questions in the session so far? Okay, here's the tumor. Here's the paper, sorry. So this is what we call it. Mixed.
We can't see your paper screen. We can only see your
Oh,
Microsoft screen.
it changed from, Okay,
You
wait,
have to
wait.
share the screen again.
Oh, okay. Let's see. Can you see it now?
Yes.
I'm not sure which side you're seeing. Is it, do you see my cursor?
Yes.
Okay, so this is what we called it. And then let me, so here is the EM image. So we have these smaller granules, and then the larger granules.
Nice.
So yeah, anyway. Cool, any
Anyone
questions?
has any questions, guys? Okay. Before you all leave, thank you, Dr. Akki. Thank you very much for a wonderful, wonderful session.
No problem.
I
You're welcome.
also quickly want to revise what we said in like 15 minutes from Kurt's notes, if it's all right with all of you. I found that Kurt's notes was really good for this one. And if we could just quickly summarize what we read, like what we saw in the session. So I'm not gonna go in detail of this, maybe I should, but solid and cystic. So if it is cystic, then look if epithelium, that is lining. So serous epithelium and mucinous epithelium, then go for ovarian type stroma. If there is ovarian type stroma, then MCN, and usually happens in body or tail, exclusively in women. And then if there is no ovarian type stroma, then think of intraductal papillary mucinous neoplasm. Again, 0.5 centimeter more than that. And if tubular, then consider the tubulopapillary one. And then if serous, like the one that he showed, serous cystadenoma, and it's benign, usually cystic, and the markers will also be like benign kind of markers. They're saying glycogen-rich stains, PAS positive. And then go to the to the solid. Solid, again, the epithelium and stroma. So if there is a desmoplastic stroma with individual glands is ductal, and if hyalinized stroma minimal, then see the cellular differentiation. If it is neurocrine, then synaptophytes and chromogranin. Acinar, then it would be more of that zymogen granules, and chymotrypsin and trypsin will be positive. And do you see squamoid nests? So that came up as pancreatoblastoma, so that you see on the pancreatoblastoma. And then if you don't see the squamoid nest, then it is more of traditional acinar cell carcinoma with all that granular cytoplasm. So that's the gist. Pancreatic ductal, I'm not gonna go in detail. Then non-invasive glandular lesions, so IPMN, we saw a case of a very nice case of gastric IPMN. So he mentioned gastric, intestinal, and pancreatic biliary being the most common. And then he also mentioned KRAS and GNAS mutations. And the oncocytic, we saw that one as well, intraductal oncocytic papillary neoplasm with abundant eosinophilic granular cytoplasm, and they are mentioning cribriform lumens as well. They will stain with Hepar. So, I mean, it looked like there is the staining of Hepar is positive. And then rearrangement in PRKACA, and this is more of to the pancreatic pathologists. Cytology, I'm not going to go in detail. So then intraductal tubulopapillary, it looks like tubulopapillary back-to-back tubules, and there'll be no KRAS mutations. It's rare and benign if non-invasive. Then coming to mucinocystic, more of ovarian type stroma and distinct ovarian subepithelial stroma. And epithelium will be predominantly columnar or mucinous epithelium. It is this important point. He was mentioning this all the time, that does not connect to the ductal system versus connect to the ductal system. So the mucinocystic neoplasms will not connect to the ductal system, unlike IPMNs that will connect to the ductal system. And then ovarian stroma, we saw that almost exclusively in women. We saw that earlier, and in body or tail almost always. And so thoroughly sample and rule out the invasive component. Simple mucinous cyst more than 1 centimeter, without ovarian type stroma. So that's a differential. And then pannins. So the pannins can be low grade and high grade. So the low grade will be pseudostratified, basally located nuclei, mild to moderate cytologic atypia, flat or papillary. And high grade pannin would be loss of polarity and abnormal architecture, papillary, micropapillary, or cribriforming. And we have to report if the margins are positive for pannins. Then coming to neuroendocrine, we don't need to read a lot about neuroendocrine. It will be organoid structure, architecture, nested cords, and everything. If less than 0.5, then it is microadenoma. So that's one differential. And then grade 1, 2, 3, he mentioned all of this. And the high grade ones are the small cell and the large cell. And small cell will be finely granular scant cytoplasm. We don't, and Ki67 is more than 100, is almost 100% for the small cell, is 60 to 80% for the large cell. So that's that. Pancreatoblastoma, this were the squamoid morules that he was talking about. So this is typical squamoid nests that are seen in pancreatoblastoma. And so looks like acinar, but defining findings is the squamoid nests. And then often there will be nuclear beta-catenin as well. So synaptophysin can be positive too. So that's that. But like because of the acinar component, it will be trypsin and chymotrypsin positive. Then acinar cell. So acinar cell, we read about the granular cytoplasm, zymogen granules, single prominent nucleolus, and that's the typical. A lobular to trabecular growth pattern, and IHC, so trypsin, chymotrypsin, lipase, amylase, BCL10 they are also mentioning. And hallmark, no genetic hallmark can cause subcutaneous fat necrosis due to lipase hypersecretion. It's poor prognosis, still better than the pancreatic ductal adenocarcinoma, but it's poor prognosis, median of 19 months. Solid pseudopapillary, we read that it will be pseudopapillae, and then with the fibrovascular cores and hyaline granules that he was showing. And then nuclear beta-catenin is the typical for solid pseudopapillary. Then coming to serous cyst adenoma, we saw a very nice case from Dr. Akki. So again, older women, bland uniform cuboidal cells with clear glycogen-rich cytoplasm. And then glycogen will stain with PAS, IHC, inhibin, and will be like sponge-like appearance with a central scar. That's what one of the fellows was also saying, with the central scar and sponge-like appearance. And then we read that, we saw that it has VHL, and rare serous cyst adenocarcinoma, so if metastasizes. And then non-neoplastic processes, I mean, these we didn't go through. I don't think that we should, like, autoimmune pancreatitis is important, like there will be dense lymphoplasmacytic infiltrate, storiform fibrosis, and so forth. That's it. All right, then. Thank you very much, Dr. Akki. Are you still here? I think he's gone. Yes. Thank you very much, guys.
Thank you.
Thank you.
Thank you.
Thank you. Thank you.
Yeah. Bye-bye.
Thank you.
Bye.